So why are we not maybe doing better, although significant steps have been made and progress? What more can we do? I think firstly, overcrowding in wards has created favourable conditions for infection spread. House of Commons Library has found that trusts with a bed occupancy rate above the government's optimum recommended level of 85% had an 18% higher rate of C. diff and a 21% higher rate of MRSA on average in 07-08. As the number of beds in the NHS has gone down, 145 NHS organisations in England, that's about 45% of the total, now have a bed occupancy rate above the government's optimum recommended level of 85%. Indeed, bed occupancy is running at over 95% or more in 13 NHS organisations, and some trusts will certainly report bed occupancy rates of over 100%, certainly over Christmas. In addition to the problems of overcrowded hospital wards, the government has maybe unwisely ignored its own advisers over isolation facilities. In 2008, the Health Protection Agency published a consultation document on C. diff, produced by the Steering Group on Healthcare-Associated Infections. The document was pretty damning in its criticism of government action. It said that there were over 50,000 cases of C. diff reported in England in 2007, a 50-fold increase since 1990, of whom 20% were in a younger age groups previously not considered to be at high risk. The steering group considered that more than any one factor, it is the failure to implement the existing guidelines described in Clostridium difficile, the Prevention and Management, the 1994 report, which note the need for isolation facilities and good hygiene that contributed to the rise. The trouble with politics, the danger in politics, is to rush to be seen to do something. This is sometimes for political gain when actually no actual gain is achieved. The deep clean was possibly a little like that, maybe a publicity stunt, if anything in the long term, to combat the problem of healthcare-associated infections. News of the World, the reports were that for the first time every hospital will receive a deep clean, designed to return our hospitals to the state they were in when they were built brand new. But the deep clean has quite rightly been widely criticised by many experts as having little or no effect. As the Lancet put it, disinfection of high-touch surfaces is what is needed, more so than removing visible dirt. Politicians must stop pandering to populism about hospital cleanliness and listen to the evidence. I think that point was made well by Peter. We need to look at causality and actually look closely at the evidence and only embark on schemes, on new initiatives that will actually make a difference. And similarly, as the microbiology expert Dr. Dancer said, the deep clean will only have an impact in the first week and then hospitals will be dirty again. What then should we do, not just to continue, but to strengthen the fight against infections? Firstly, we need, certainly in government, the right levers. It should be a basic rule of any sort of social policy that payment should reward success, not failure. Therefore, there is certainly an argument to ensure that hospitals should not be paid or not be paid in full for a treatment which leaves a patient with an infection like MRSA if this was preventable by proper standards of care and cleaning. Secondly, there must be clearer lines of accountability in hospitals so that any avoidable problem can be dealt with quickly and efficiently, or better still, avoided in the first place. That's why we are suggesting that all NHS staff have a contractual right, an obligation to protect their patients by raising concerns about practices at their hospitals directly with the regulator, the Care Quality Commission. It is important that staff are able to raise concerns simply and anonymously without having to go through the full legal whistleblowing and rather daunting process. Although obviously this route should be available if they want it. Therefore, any concerns need to be treated in confidence and have no impact on the person's employment. by giving frontline staff the ability to respond to systematic problems within their work environment. The fight against healthcare-associated infections, as well as other areas, of course, of frontline care, will be significantly improved. Thirdly, we recognise that infection cannot be rooted out while hospitals are still treating patients on crowded wards, without the facilities to isolate those with suspected or confirmed cases of infection. Single rooms not only provide patients with privacy and dignity, eliminating the fear of being placed in a mixed-sex area, they are pivotal in the fight against hospital infections. To that end, we need to end what is undoubtedly a scandal of mixed-sex accommodation and increase the number of single rooms in hospital as and when resources allow. These are allocated on a needs basis, and if we form the next government, the Department of Health will make single rooms a priority for allocation. This will mean that all hospitals have the single rooms that they need to isolate patients with an infection. Of course, for whoever is in government and whatever is achieved in getting infection rates down, there will always be more to do. There will always be room for improvement. But the fight against hospital infections is essential, both in ensuring patient safety, but also in retaining public confidence in the NHS. All too often, anecdotally, we hear stories of patients refusing to go to A&E because they're scared of getting an infection. And that is why we must do more to bring down the rates of all healthcare-associated infections in all trusts across the board.